On behalf of the Patient Safety Authority, I'd like to welcome you to this webinar titled Influencing a Culture of Learning from Diagnostic Errors at a Health System. My name is Bob Yanish, and I'll be your moderator for this program. The webinar will be available in a few weeks on the Patient Safety Authority's YouTube channel. We welcome any comments or questions, and all materials are provided for educational use. Now I'd like to introduce our speaker for the webinar. Dr. Divvy Upadhyay is the program lead and scientist in the Division of Quality, Safety, and Patient Experience at Geisinger Health System. Divvy's current focus is on establishing and learning from a system-wide program to address diagnostic errors at the Safer Diagnosis Learning Lab, which is a unique collaboration between Geisinger and the Baylor College of Medicine. He's the principal liaison for the operations and research teams and manages Geisinger's Committee to Improve Clinical Diagnosis while leading the investigation and evaluation of the research initiatives. Dr. Upadhyay, I'll now turn the program over to you.
Thank you, Bob. Hello, everyone, and thank you for joining this session today. My goal here is to introduce to you what we've been doing at Geisinger to address the challenge of diagnostic errors and how our focus is on creating a culture of learning and promoting the culture of safety. I appreciate the invitation from the Pennsylvania Patient Safety Authority. This is just a broad overview. The three basic learning objectives today are to maybe discuss briefly the scope and types of diagnostic errors, identify, like I said, how one healthcare system is proactively approaching this challenge. And then I'll give you some examples of how at our Safer Diagnosis Learning Lab, that's a unique collaboration between operational and research teams, how we are using a kind of a lead framework, a 5-point action plan to capture and mitigate diagnostic errors. Here's a very brief roadmap. I usually like to present this just so you know, you have a sense of what's coming along in the next few minutes. I think because of the the credit hours, I need to present for 50 minutes and then we'll have a Q&A. But I really, Bob, at any time, please feel free to stop me. And if there's a greater need for Q&A, we can start it sooner as well. So I think I'd like to begin with a couple of cases just to set the context, briefly discuss the challenge of diagnostic errors. Quite honestly, it's not rocket science. I'm pretty sure that most of the attendees today have quite a good sense of what diagnostic errors are and the complexities associated with them. And then I'll briefly discuss the Committee to Improve Clinical Diagnosis at Geisinger, our unique initiative, the Safer Diagnosis Learning Lab. I'll briefly mention a few other sources that might be useful for the attendees. And I'll wrap up with the lead framework that kind of guides our work here. And then we'll have a Q&A session. Usually, sometimes we leave this for the end, but I'd like to bring this up front. I'd like to recognize my team here. This is key. It literally it takes a team. On the left side of your screen, you see the Committee to Improve Clinical Diagnosis. You can see Dr. Turetti there. He's second from left. Dr. Dennis Turetti is the executive sponsor, and until very recently was the chair of the Committee to Improve Clinical Diagnosis. He's the founding chair. Right next to him, you can see Dr. Mehta, who is now the current chair. But this is the the top leadership at Geisinger that's focused on trying to address diagnostic errors, along with the overall C-suite or executive leadership of Geisinger healthcare system. On your right side, you will find Dr. Hardeep Singh. He's an international expert, and some of our team members, including my project manager, there's Sarita, and our collaborators in Houston, Ashley and Trey. But in any case, this is an interesting story where there's a heavy operational focus on addressing diagnostic errors at Geisinger, and we've had a unique partnership with Dr. Singh and his lab in Houston to create this learning health system, so to speak, on diagnostic safety. The reason I think I've spent a few seconds on this slide is it's very important to know that there are multiple stakeholders involved, and this definitely needs a large team if you really seriously want to address this very complex issue. Usually, if I had my way in an in-person setting, I would have brought up this picture and I just generally ask if you know this cute kid here. And since we're not in an in-person session, in the interest of time, this sweet boy here is Rory Staunton. Some of you may have heard his name. If not, here's a story. This is a 12-year-old boy. He cut his arm during a basketball game in school, and I'll call that as day one. So he goes to sleep, and the next day he wakes up. He complains to his mom about some leg pain, and there's some vomiting, nausea. So quite obviously, the parents are concerned, and they do the right thing. They right away call the pediatrician, and they describe the symptoms. Luckily, they get a same-day appointment, and they meet the pediatrician the very same day. So this is day two. During the visit to the physician, Rory complained of pain in his leg. There was a history of vomiting, a high temperature, went up to nearly 100 and 203. Now, this was, of course, discovered later, but I'm just mentioning here chronologically. At this visit, skin mottling was present, but was not considered serious. And of course, the leg pain was attributed to the fall in the gym. The parents remained concerned. But given the constellation of symptoms, the pediatrician attributed the scenario to some GI or stomach bug. This might have led to some inadequate history, and it kind of diverted the momentum towards gastroenteritis. So the pediatrician told them to take Rory to the ED for rehydration and for further workup. Now, the parents take the kid to the ED right away, where he was given fluids, Tylenol, but eventually, after about an hour or two, was sent home with the same diagnosis of gastroenteritis. Now, again, this is some of the retrospective information that was discovered later, but at the ED, he had some worsening vital signs. For example, his respiratory rate was at 22, heart rate was at 143. Some of the blood tests in the ED showed, abnormal sodium. There was leukocytosis, and interestingly, there was bandemia. Now, this is the report. This is all after the incident. It was discovered, and there you can see there was quite significant bandemia. In any case, all this abnormal blood work in the ED was received after the patient was discharged. These significantly abnormal results were not communicated to the patient's family, or the pediatrician. So as a result, the severity of the illness was missed. In any case, the parents took the kid back home, and unfortunately, he continued to worsen. So the next day, they came back to the ED. This is when all the abnormal test results were discovered. He had to immediately be taken to the ICU. And to cut a long story short, a very sad story here, he basically had sepsis, and he unfortunately passed away with multi-organ failure the following day. Now, this case became, a major issue because his parents became advocates in honor of his life. And as a result, New York has some laws called Staunton laws, if I'm not wrong. And their focus is on creating awareness about sepsis and reducing misdiagnosis in sepsis. This is a screenshot taken from their website in case you're interested. But they have a lot of advocacy around sepsis. My intention here was to just give an example of how there were some clinical misses at the pediatrician's visit, some anchoring or availability bias trying to focus on the gastroenteritis. And then later there was several issues at the ED, most important of which was not following up on critical abnormal test results. Here's another story. This again, in an in-person session, I would have asked the audience to guess, but you could still, as I give you details here. In late September, a 41-year-old male patient, this is in Texas, presents to the ED with a temperature of around 100, dizziness, nausea, abdominal pain, headache, and decreased urination. he was at the ED for about, a few hours. And while in the ED, his temperature even went up to 103. He rated his pain at 8 on a scale of 1 to 10, and the nurse recorded his recent travel history to Africa. Some investigations were done. A CT scan of the head and the abdomen was ordered during the CD visit, and it showed no evidence. It was largely, I think, normal. But their diagnostic momentum for the clinical team that day in the ED was sinusitis or just some maybe flu, God knows. He was prescribed some antibiotics, told to take Tylenol, and he was discharged. 2 days later, the patient worsened and returned to the same ED and was subsequently admitted to the hospital. At this point, I usually ask any in-person audience for any guesses. Now, this, by the way, was the patient 0 in the most recent Ebola outbreak in the US. Just to go back a screen here. So the first Ebola patient actually walked into the ED, had dizziness, nausea, fever, abdominal pain, gave a history of recent travel to Africa. And this is at the time when CDC had already prepared all the hospitals. And this hospital in question actually did undergo that preparation or the training to identify any possible potential cases of Ebola. Now, but this was a missed opportunity, and we actually wrote about it. This was way back in 2014. But this is just to show you how sometimes, even in a pandemic or in an epidemic situation, misdiagnosis can happen. And this actually had a lot of impact on the healthcare system. They had to take out full-page apology ads in the newspaper. It even led to a testimony in the Congress. They had to admit that, in the newspaper on the visit to the ED, we did not correctly diagnose his symptoms as those of Ebola. For this, we are deeply sorry. This could be Ebola, this could be anything else. The point here, sharing these two stories of, the pediatric sepsis, or in this case, the Ebola patient 0, diagnostic errors happen, and they happen quite often. They are a major challenge, but there are often hurdles in recognizing them and learning from them. And sometimes, most times actually, they have a very large impact, especially, of course, first on the patient and then on the healthcare teams. Here's a little experiment. I really hope it works out. Just to make this a little bit interactive, let's play a few question and answer games here. There'll be a question that comes on this screen as well as on your cell phone screen. And you have about 30 seconds to answer this. So what do you most closely identify as? Sorry, I should have read out the question for anyone on the phone. And the options are patient safety professional, risk management professional, clinician, or a healthcare administrator are the 4 options. All right, so not surprisingly, we have 73% of the respondents are patient safety professionals. We have a few clinicians, few administrators, and so the majority, almost the entire room today is patient safety and risk management. That helps me understand who I'm speaking with, as well as I think this is the right audience. Great, let's go on to the next question here. This is a poll. Does your hospital or health system currently have a program or initiative in place to address diagnostic errors? All right. Wow. Half of the participants in today's event belong to an organization where they are currently, they are looking at diagnostic errors. That's quite encouraging, really. And 1/3 don't have anything yet, and there's almost a few that don't know. This is fine. So at least half the people in today's room know about a program in their place. That's great. Another poll. This is just for us to understand, what are we really talking about, though none of this must be new to most of you. So which of the following sound like diagnostic errors? You can choose multiple options. Is it a missed follow-up of an unexpected finding on imaging, incorrect medication, wrong site surgery, or inadequate physical examination to rule out a particular condition? All right, Maybe the time on that was short, I apologize, but this is good. So 100% of the respondents agree that a missed follow-up of an unexpected finding on imaging is a diagnostic error. Um, Almost 90% of the participants also agree that inadequate physical exam is a diagnostic error. Interestingly, we have 40%, nearly 40% of participants who think that incorrect medication or incorrect doses or wrong site surgeries could also be diagnostic errors. And I'm not going to go into black or white. There's literally no verdict here, what's right or wrong. But as soon as we discuss the definition of diagnostic errors, it might become apparent that wrong medications or wrong site surgeries may not just fit in the widely accepted definition of diagnostic errors, but again, like I said, it's nothing like it's totally wrong. Let's go on to one more question here. True or false? Let's say a scenario. Is it a diagnostic error if the doctor doesn't order a colonoscopy for a patient with iron deficiency anemia and a fecal occult blood test that's positive? Slightly clinical, but I'll explain the context in a sec. Very good. So I think 23 participants agree that it's a diagnostic error, 10 don't, which is fine. Here there were two contexts that I wanted to bring up, and we'll understand more when we look at the definition of diagnostic errors. Here there is a clinical scenario where the appropriate action that a clinician should take, widely believed that they should take, is order a colonoscopy and make sure the patient completes that colonoscopy so that they can either rule out or make an early diagnosis of, let's say, colorectal cancer in this case. The other thing I wanted to bring up this case for is because a lot of people sometimes think that population health is not really connected to diagnostic errors. Sometimes there's a gray zone there. Population health includes screening tests, but I think many people here may agree, we see a lot of missed opportunities when either screening tests or diagnostic tests are done and abnormal values or abnormal results are not appropriately followed up. So this is indeed a diagnostic error or a missed opportunity. Let's go for the last one here. Which of the following options do you think is the leading type of paid malpractice claims or falls as the highest proportion of total payments? Are these medication errors, surgical complications, OBGYN related malpractice claims, or diagnostic errors? All right, very good. 2/3 of the room, 2/3 of the audience today think it's diagnostic errors, which is exactly right. Diagnostic errors are the leading type of paid malpractice claims, and even among the payments, they have the highest proportion of total payments. So this is good. This is at least some semblance of an interaction. But let's see. I think if we're having some fun, we should let it continue. I think this will now give us some winners. So LP is on rank 3, CC on 2, and the spotlight goes to Jillian R. I hope I pronounced that name right. And we have some runners of the Garden Girl and but anyway, this was just for some fun. I think we are at about 1/3 of the talk. So let's go back to the discussion here. So our working definition of diagnostic errors is missed opportunities in making a timely and accurate diagnosis. This largely comes from the work done by Dr. Hardeep Singh. Definition of diagnostic errors has been written about. There are some papers that you can go read. But eventually, most of you know that the Institute of Medicine, now the National Academies of Medicine, came out with their report on improving diagnosis in healthcare, and they suggested that the definition of diagnostic errors is the failure to establish an accurate and timely explanation of the patient's health problems. And they added this point, or communicate that explanation to the patient. Now, this is a very important aspect of care, because we often tend to look at diagnostic errors as, issues with physician judgment or, the clinical misses. but the IOM kind of expanded the definition to include the fact that the patient has a full understanding of their diagnosis. And if that's not the case, then it's a diagnostic error. But for more practical and working purposes, I'd like to suggest, for this, at least for this talk here in the context, is that we look at missed opportunities in making timely and accurate diagnosis as diagnostic errors. Like I mentioned, they are the leading type of paid malpractice claims. Most medical error studies find that 1/3 of errors are usually errors in diagnosis. A study done quite a few years ago by Dr. Singh and his group actually found that estimated that at least 5% of US adults, and it was a big news item, I believe, in NBC, that an estimate is 12 million patients might potentially have missed opportunities in their diagnosis in the outpatient sector in the US when you just extrapolate the data. Postmortem studies, autopsy studies, and several other types of studies have put the rate of diagnostic error somewhere between 10 and 30%. But it's a major challenge. It's everywhere, and it's a challenge that we all need to address. Culturally, we have avoided usually discussing about this other than in medical legal context. And that's what was pointed out by the IOM report as well. The 2015 Institute of Medicine report on improving diagnosis in healthcare. It said categorically that there are very few organizations, if any, that have processes in place to identify diagnostic errors and near misses in clinical practice. That said, collecting this information, learning from these experiences, and then implementing the changes based on those lessons are critical for achieving progress. And they recommended that healthcare organizations should promote a non-punitive culture that values feedback on diagnostic performance. Now, interestingly, this was happening in parallel to the efforts at Geisinger back then in 2014, 2015. And so here's where I'll quickly, convey the story of what's happening at Geisinger as a case study. In 2014, along with the Chief Transformation Officer at that time, there was a big momentum on trying to address diagnostic errors. And this is where Dr. Dennis Teredi, who for a couple of decades was the chairman of medicine at Geisinger, had assumed the role of Associate Chief Medical Officer and taken on this challenge. The Diagnostic Error Work Group was formed, to identify and categorize errors to see the patterns. This evolved into a full-fledged committee to improve clinical diagnosis with a formal program and a charter and a reporting structure. And their broad goals of this evolution, from a work group into a full committee, they identified clinical champions, and they adopted their definition, so they set their framework and they prioritize areas of opportunities of what they want to do, and they define program goals. Now, why am I saying this? I'm not mentioning this just for historical context, but this is exactly what any organization could do. And this is what I'll come to, eventually in the LEAD framework that I mentioned. You can start small and go big, set your goals, define your framework. But this is classic program development. At our institution, the Committee to Improve Clinical Diagnosis has a mission, and the mission is, continued pursuit of clinical and diagnostic excellence. To proactively reduce diagnostic errors, to improve patient outcomes, but most importantly, promoting learning and a culture of safety. In a very psychologically safe environment, we want clinicians to receive the feedback in a very non-punitive way, and that's just the key intent of our program. Among our functions are to analyze and categorize the diagnostic opportunities that we collect. We identify the lessons learned. We develop and discuss systematic solutions to these, processes and to reduce these errors. And we maintain the goal of promote the Geisinger's goal of becoming a learning organization to increase transparency around discussion of these errors and to create these learning opportunities, eventually just to improve the care we offer our patients. Key organizational elements that helped us, and quite honestly, this is to give you a sense of how I'd just like to check if I'm Bob or Shelley. Can you still hear me?
We can, Divvy.
Thanks. I just got a note from WebEx saying that anyway. So the key organizational elements here that helped make this an institutional or organizational priority are that we had active leadership support, from the C-suite, from the executive leadership. We have a very engaged division of quality and safety. We have our stakeholders, our physicians who are our champions. We have our informaticians, and the fact that Geisinger is an integrated healthcare system, and we have longitudinal data that helps us. And safety is one of our prime goals. Culture of safety is what we strive for. So all of this came together to provide this conducive environment for this program to, to succeed or to at least be in place. This is to give you a sense of how multidisciplinary our CICD membership is. We have from different institutes, we have leading, directors, clinicians at different stages of their career. We have all major departments, including quality, safety, patient experience, informatics, not just the clinical departments. Naturally, a slightly heavy focus on medicine, but this is what our multidisciplinary committee looks like, which meets every 2 weeks to review cases and to look at patterns and all the functions that I already explained. This is the process, and this is how we've laid out the framework. We collect cases with diagnostic errors from different sources. Risk management is a very natural, traditional source. We encourage our clinicians to directly share cases with us. We look for patient concerns about diagnosis, and we are developing some electronic triggers. And I'll go back to these sources when I discuss the lab to show how we are extracting information on potential diagnostic opportunities. The cases are put through a CI/CD review process, and the cases with opportunities then go along with a feedback toolkit to our department and quality directors, requesting them to do, essentially 4 major big ticket items. Provide non-punitive, constructive, supportive feedback to the individual providers or the team. Disseminate the lessons learned across the department or across the system. And in the analysis, if it appears that we need an action plan, that action plan is developed. The CI/CD facilitates the development or the monitoring of that action plan. And if there are system issues that are identified, we request them to close the loop back with us, either way, so that we can then make sure that we are able to facilitate or move forward these system fixes. But this, more or less, from a 60,000-foot view, is our process. And a major part of our initiative is encouraging our physicians, and that's what we're trying to influence this culture of learning, and give them some safe space to share cases with us. And we've had a good response. We request them to share cases through a hotline where they can even leave anonymous voicemail, or they can send us through our electronic medical record a message, or they can just page us. I get a page directly as someone identifies, or quite honestly, once you're in a system and you try to do this, you develop relationships where people just directly remember to send you cases with such learning opportunities. Just to wrap up here, the goals of our, the intent of our work of this committee and of the organization is to encourage transparency, to develop feedback mechanisms, to expand the learning, to find system solutions, and to influence culture positively for safety and learning. At this point, I'm going to take a short break to show you a video because we don't have any faces, so I thought this will be a nice idea. You can see some faces and hear someone other than myself as well. I hope this works out.
Geisinger is a large rural integrated health system based in Pennsylvania with sites in New Jersey as well. It includes 13 hospitals, a level 1 trauma center, a health plan, as well as a medical school. There's no clear-cut outline for organizations to follow in addressing diagnostic errors. From a hospital perspective, it's essential that we address this as part of our responsibility to caring for patients.
We have the committee to improve clinical diagnosis, and the emphasis is just that, to improve clinical diagnosis, to avoid errors that could potentially happen, to educate our colleagues and ourselves.
We have probably about 20 members on the committee representing all specialties and levels of experience. We have some folks who are fairly young in their careers and others that are more senior.
We have a hotline through which anybody can convey to the committee that a diagnostic or a potential diagnostic error has been made. These can be self-reported or reported by a colleague, not with the goal of pointing fingers at anyone, but to improve patient care.
We're looking everywhere. We're looking in the emergency room. We're looking in the inpatient setting. We're looking in the outpatient setting. Anywhere these things occur, we need to find them, and we need to investigate them, and we need to learn from them. That's the ultimate goal.
I think for physicians in general, admitting that we can make mistakes, that's a pretty tough one. We've all gone through this aggressive, prolonged, competitive training process, and it's really hard to say, I don't know. And it's really hard to say, I made a mistake.
In essence, the Committee to Improve Clinical Diagnosis acts as a facilitator so that departments, divisions, and ultimately physicians are empowered and have the opportunity to reduce preventable errors and improve the diagnostic process, thereby improving the patient care that we deliver.
How can we as a team review this case and build in systems and changes so that we don't have the same problem happen again?
It's a very sensitive time for a clinician to hear about an error that they may have been involved with. So we've tried to perfect a system. It has to be done in a non-punitive way. It has to be done in a collegial way. So that it's really a learning experience. The key is to actually share it with those who've not experienced the diagnostic error to help them be more attuned in the future to avoid the same error. That's the whole purpose.
The main functions of the committee are to develop strategies to identify and specifically target diagnostic errors, to begin to categorize the errors so that we can understand some of the origins of errors in the clinical care process and the diagnostic process.
If it was a system problem, then the system problem needs to be fixed. If it was a problem related to lack of knowledge or a misinterpretation of a diagnostic test, then that needs to be addressed. So the problem could be systemic or it could be individual.
Diagnostic errors is not yet translatable into measures that can be paid for or that can be reported. But one of the aims of the Safer Diagnosis Learning Lab and the committee is to actually learn and provide feedback to physicians even when there is no harm.
What they're striving for is, a very noble gesture, which is, how do we work on this aspect of medical care that we don't have down, that is not completely correct, so that we do get it better.
It's difficult. It's not part of our history in healthcare to be this open and transparent about diagnostic errors. But, moving forward, there's no looking back at this. There's no way we could ever justify not doing this and not doing it well.
So, my intent there was to just, share more voices about how a healthcare organization looks at this problem and is trying to, deal with it and address it. There's just multiple perspectives there, things to take care of. But that story largely was about the Committee to Improve Clinical Diagnosis, the operation aspect. In our story, a key moment was when there was a collaboration between this operational leadership and research expertise based in Houston, led by Dr. Singh, and funded by the Moore Foundation, which created this exclusive Safer Diagnosis Learning Lab, so to speak. This is an experiment in trying to understand how we can create a learning health system that is focused on diagnostic safety. So truly the CI/CD and the Safer Diagnosis Learning Lab are have a lot of overlap, and they coexist, and it's a very unique partnership where other organizations could also look at partnering with research expertise so that we learn as we implement diagnostic safety initiatives. Um, Moving forward, this is the concept of learning health system. Just quickly, you basically look at a problem, you analyze it, you create data. That data leads to some knowledge that impacts practice or practice improvement. And then again, data is generated, and this cycle keeps going because learning health system is consistent, constant learning as you improve. Um, in our lab specifically, I had the role and this opportunity to be the liaison between the operations and the research team, and then trying to implement the different projects as well as the operational part of the committee. You gather and learn from actionable intelligence while you're developing this diagnostic safety measurement and improvement program, and then you just generate knowledge about how health systems can enhance the safety and accuracy. This is done in each project we take, in each action item that we follow, in the system issues that we identify. The reason I'm bringing this up is just to show that work such as this needs resources. And partnering with research expertise, so people who are familiar with what is done or what could be done, is helpful and can give a lead if any organization is interested. Very quickly now, I think I have about 9 minutes, 10 minutes left. So I wanted to introduce this framework. This is the Safer DX framework, a socio-technical work system, a model which you can read more about. This is recommended by Dr. Sittig and Dr. Singh. And even the IOM adopted this map of diagnostic process, or the way to look at the diagnostic process. When we tend to look at where the breaks or where the errors could possibly happen, we look at 5 dimensions. The primary dimension is the patient-provider encounter and the initial diagnostic assessment, where the physical exam and the initial diagnosis is generated, the history is taken, the history is elicited. The next dimension that we look at is where the diagnostic tests, basically radiology and pathology, where the tests are done and interpreted. The other area that we focus on is referrals. That's one more place where we see some opportunity. And then, of course, follow-up and tracking of diagnostic information. Primarily, this comes down to abnormal test results. And then, of course, the fifth and the most important dimension is the patient. Not only looking at the impact of the error to the patient, but also trying to understand if there were any unfortunate patient factors. Sometimes there are affordability issues, sometimes there's understanding issues, but there are several. And each of these 5 categories, we have subcategories when we do our analysis. What it led to for us was developing a shared mental model to look at each case that comes in. Over the last 5 years, we have a collection of more than 500, 600 cases. So this is how our team was kind of, trained in looking at cases. There are many tools out there. Not many, sorry. There are a few tools out there, but this is one of the ones that we use. This is the Safer DX instrument. It's a set of 13 questions that helps you think through those 5 dimensions and the diagnostic process. And you review cases based on answering, whether there was an opportunity in the history, in the physical exam. Over a period of time, like it's happened with myself and my team, we become, this kind of gets imprinted in our mind. So we don't necessarily have to use the tool, but the concept is what is very important, and the 5 dimensions. It helps us categorize and, learn. Here's an example of how we use this 5 dimensions or this categorization. When we look at our cases, when we do the analysis, we are able to dive deep in and understand or identify that around 2/3 of our cases or opportunities, so to speak, are related to either cognitive issues, maybe, or knowledge gaps. That's what you mostly find in the patient-provider encounter dimension and the diagnostic test interpretation dimension. The rest of them are, of course, referrals and follow-up and test result tracking. That's more of system issues. But this is what the benefit of analyzing this. You can understand what proportion of your cases could be attributed to system versus knowledge gaps or cognitive issues. And then, what do you find? This is a variety of diagnoses up in front of your screen in a word cloud here. This to you indicates, and most of these are, diagnostic opportunities. It indicates to you that diagnostic errors are inherently condition agnostic. They're not specifically related to any condition, or they don't occur more in one rather than other. They can just occur anywhere because that's the nature of diagnostic errors. At the same time, the way we receive cases or look at cases, there might be a bias. So we definitely find certain areas where it's easier to identify diagnostic errors. By example, stroke or sepsis or cancers. But you find them in multiple different scenarios, in multiple different settings, and in multiple different conditions. Let's say, for example, if you take cancer as a leading area where there is diagnostic opportunities, we have the ability to dive deeper into those cancer cases and identify what might be the opportunity. In our case, we found that there might be a significant opportunity in follow-up of abnormal test results. And that has led us to, investigate and pursue a line of action where we are trying to make sure that we do not miss abnormal test results in different areas. This could be follow-up of incidental or unexpected findings on images. This could be as varied as abnormal blood culture results, abnormal creatinine results. So different types of results, you can capture this, and each system can identify its own priorities and do a deep dive. While that was a quick example of a system issue, how to identify and pursue. Here's what we invested a lot of time in. This goes back to our concept of creating learning opportunities and providing feedback. We created a feedback toolkit of sorts that we give to our directors so that they can provide feedback in a supportive and a constructive manner, because this is the most feared event. No one really appreciates getting an email from the director saying, hey, something went wrong in a case, let's meet up. So we give some recommendations, and we've actually published about this. So in the interest of time, I'll move on. But we did a small pilot experiment in 3 of our departments, and this paper was published in the Joint Commission Journal. Overall, we got very good feedback from the recipients of the learning opportunities where the directors provided feedback. The recipients reacted very positively, and so did the providers of feedback. But this is out there. This is an open access paper. I encourage you to see it if you're interested in developing this feedback mechanism. Then, as I said earlier, you can engage patients. We've published this paper too. This is learning from patient complaints. This is, of course, a small research project. We're trying to see how we implement this in our system. But patient complaints is a rich source of data on identifying, diagnostic concerns, so to speak, and then following up and doing a deep analysis of the diagnostic errors. We are engaging our patients in those who access open notes. Now everybody has access to doctor's notes, their clinic encounters, and we encourage our patients in this small pilot experiment to review their clinician notes for any diagnostic concerns. But patients and families, the point here is patients and families are a very good source of seeking feedback on diagnostic concerns. The other area where we are, invested in is developing tools, electronic algorithms to extract some data with, some substantial signal for diagnostic events. And I'll give you an example. We generally refer to them as triggers, but the whole idea is because you can't review every patient encounter and every medical record, you create some algorithms to narrow it down to where the potential for diagnostic errors is high. Some examples here. We call this the care escalation trigger, where a generally okay person on the med surg floor, for example, is unexpectedly sent to the ICU, or there's a rapid response which was unexpected in nature. Or we look at unexpected admissions after a primary care encounter or a treat and discharge from the ED. And then we have, of course, criteria that helps us narrow down. But the idea is these concepts of unexpected admissions or unexpected care escalation help us narrow down medical charts or patients where we try to look for, what might have gone wrong, what could have been done differently, if at all. Here quickly, coming towards the end, let me just look at the time here. So I'm going to mention a few sources here. A lot of the measurement and evaluation sources were summarized recently in this brief from AHRQ. It can help you understand what different mechanisms are there to measure diagnostic errors, just for gaining an internal insight into how big the problem might be at your organization. This same group, I think, has also recently put out a leadership manual just in the last couple of days. I think this is the MedStar Alliance. The Leapfrog Group, this is again a national initiative, again funded by the Moore Foundation. And the idea here is that they want to produce a hospital awareness, best practice recommendations, and then maybe rate and rank hospitals and how prepared they are to learn from diagnostic errors or diagnostic safety events. Our host today, the Pennsylvania Patient Safety Authority, are a unique organization. I think not many states, if any, have such an organization. They have dedicated now a center of excellence to diagnostic safety, and I think the entire team here, I think led by Becky and all her colleagues, are trying to develop an organizational readiness assessment for Pennsylvania hospitals, which is going to be interesting because it's going to help us gather some resources and some shared mental models, so to speak, to look at this issue and this challenge. I want to put a word out there. They do deserve some credit because they seem to be one of the leading funders of work in diagnostic error space here. This is the Moore Foundation. Most of you should be aware. If not, if you're interested in the diagnostic error space, they currently have a 6-year-long $85 million investment in diagnostic excellence. They're more focused on creating measures of diagnostic performance right now, but you can find more details on their website. I want to close with this. I want to wrap up with this framework that's come out as a preliminary lesson from our work with the Safer Diagnosis Learning Lab and the Committee to Improve Clinical Diagnosis. This sort of a 5-point action plan. We think it's important if you have a virtual hub to coordinate the activities around diagnostic safety. In our case, it's the Committee to Improve Clinical Diagnosis. So just imagine all that you heard from those different people, the video that I showed, or the functions and the multidisciplinary membership that I described. And one of the chief goals of this such a virtual hub or this initiative should be to focus on measurement for improvement. It's not mostly for ranking or rating yet. Internally, we can do a lot of quality improvement if we focus on what our priority areas are. The other important initiative, as I've described before, we encourage our clinicians to share cases. We've created platforms for them to send us cases. We encourage them to be involved in the learning exercises. We are now working with our academic affairs to develop, cases where we can extract learning opportunities and teach residents or fellows about cognitive biases. But clinicians are one of the top stakeholder groups that you need to engage with. Usually a top-down approach wouldn't work here. The other big factor is learning from patients. Develop an accountable culture of engaging and learning from patients. And of course, all of this learning leads to this learning health system where you use the data to create improvements. So whether at our place it is, the sponsoring of this program called STARE, we have a system to track abnormalities of importance reliably. This is something that's been funded because we found opportunities there. Or it's about following up on unexpected findings appropriately, but a number of system initiatives that we've generated. But anyway, this is to wrap up. This is the 5-point action plan. And this paper is linked below that has more details for those organizations that might be interested. And thank you. I hope I didn't exceed my time, but Bob, back to you. Thanks.
Thanks, Dr. Upadhyay. This concludes the slide presentation of our program. We'd now like to begin the question and answer period. If you have questions, please type them in the Q&A box found at the bottom of your screen. If you click on the 3 dots, then click Q&A to open the Q&A panel and direct your question to all panelists, and we'll try to get to as many answers as possible, or as many questions as possible. We had a couple questions that came in. First is from Lori. How does the program measure the impact of the feedback to understand if the sharing of knowledge is creating change both in the individual and organizational level?
That's an interesting question. So I think it's about how do you measure the impact of a feedback program? It's never easy to do so. When we ran a pilot, what we did is we surveyed those who were receiving, and it was anonymous. You know, they answered a 5-question, and that's the paper that I was mentioning that we published. Now, eventually, one other metric that we think, you know, is an indicator of good reception of all of this is when clinicians share more cases with you. You know, one of the reasons they share more cases with you is because they believe in the learning process associated with the program. And of course, then we try to get feedback from different departments and department directors as to what they're hearing on the ground. You know, we try, at least in our organization, we're trying not to be too prescriptive and give a lot of flexibility and room to individual directors and departments, because that kind of creates some space for organic growth, so to speak. Thanks for that question.
Okay. Another question. How does the program measure the impact of the feedback to understand if the, no, we did that. I'm sorry, I moved up. Here we go. For the triggers, I'm wondering what the hit rate is for errors. Presumably you review the charts, some were errors, some aren't. And what's the overall percentage of the errors for the triggers?
Very good question. Different triggers have different concepts, and they result in different, shall I use the word, positive predictive value. In one of the recent pilots that we did, and we shared that data at a recent conference, you know, when we looked at unexpected admissions after an ED visit, we found approximately 25-27% positive predictive value, if I may use the word, from the one who asked the question, the hit rate. Now, yes, we did review 100 charts to get those 25. So yes, there is a resource question there, but at least there is some promise. And you know, further research or further work into this may bring up factors where we could develop algorithms that could reduce the human work involved and enrich the case sample. But just to give you an example, that was the ED example that you know, I remember a 27% positive predictive value. And those papers, the previous versions of those papers have been published by the Houston team.
Great. We still have a few minutes for questions if you'd like to use the question and answer box on the right-hand side of your screen. Another question came in. So what are the challenges you face in running such a program? I know it's a broad question.
This is a tricky one because, as most of you know, this is a monumental task. And if I were to highlight one or two of the biggest challenges, I think it is in engaging appropriately with all stakeholders involved. You know, you need equal participation and engagement with your senior leadership as much as you need it with frontline clinicians. That takes a lot of effort. And then, of course, for anything in this day and age, you need resources and, you know, proper time allocated. This is not a 1 or 2 month project or a 6 month project or a QI project or something that someone might want to add to their CV. I don't mean to sound cynical here, but truly this is something that needs resources and dedication from healthcare systems. And I think this is constant hard work. That was one of the challenges. Of course, we had a small team there, but this is what the intention of the learning health system was, to experiment what healthcare systems can do. Thanks for that question. Yes, the challenges are numerous, but I think appropriate buy-in from stakeholders.
Another one, piggybacking on that, how do you engage providers to work with you? Outside physicians, physician offices, even patients.
That's very interesting. We have not yet directly reached out to patients because that work still needs more time. But the way we engage with patients is we look at the complaints and the grievances that they're sending in, and we're looking for diagnostic opportunities in those complaints. But engaging with providers is a challenge in itself, and we need this constant work. We've seen sometimes a variation in. We have 1 or 2 good months where a lot of clinicians share cases, but then we have something. For example, in the last 1 year, 1.5 years, we've seen COVID impact our physicians, and we saw a decline in the number of cases shared. That could have multiple reasons behind, but the idea here is you need to be consistent and constant, and you need to create a psychologically safe space for them. Now, do I have an answer of what is the 1, 2, 3, 4 things that you can do? I think all of that involves the culture of that local department or that local hospital at times. And the more allowing the culture is to openly, transparently share cases and learn from each other without doing the blame game, the better such an initiative can progress. Now, this is just a philosophical or editorial answer here, but that's what we do from one case, learning from each case.
Okay, well, about a few minutes past our time. Dr. Upadhyay, I thank you so much for taking the time out of your busy schedule and enlightening us with this program today. It was fantastic. Again, I want to thank everyone for joining us today. If you experience any issues accessing the evaluation or our certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel at shmixell@pa.gov. This concludes our webinar. Thank you.